And I walked into the clinic after getting my Valium. That's all that they give you there, just so you know. If you go to Albany, that's all you get. Went for my Doppler. It showed I was stenosed. Went in an hour later. They did a little incision in your groin. Did my little feed. I was 60. Just so everybody knows about stenosis, how numbers-wise. I was 60% on the left side, 60% on right. 3 balloons on left, 2 on right, and 3 in the azygos for me. So I had a lot of ballooning happening during the period. I had some of the immediate miraculous recovery that others have seen, but some I haven't, and some came as sort of the days went on. I have good days, I have bad days, but I have more good than bad. I would do it over again like anybody on here, I think. And I just can't wait for the day that it comes to Canada. Fingers crossed, everybody. I'm really thankful for all the people that are up here telling their stories. I think they're important to tell. I'm the emotional one, as you know. Because of all the positives I've seen, I want all the rest of the people in Canada to have those positives as well. And that's my story.
Story too, but it's just far too long. It's sort of a combo of everybody's story up here, but I have to say that I certainly have seen a lot of amazing improvements, and the biggest one for me has been my energy. I don't even want to go to bed. I have so much energy, it's insane. So that is really the hugest one for me, and but you do get really good drugs in Cabo if you want to go there. I remember being on the table because they had to knock me out for the MRI, which is another very long story. But when I was in the procedure room, I was pretty much doped up, and I remember the anesthesiologist rubbing my head, going, "Sweetie, this is really gonna hurt. This is really gonna hurt." And it does hurt. I'm not kidding you. It does hurt, but it's just sort of one of those pains where it hurts and then it just goes away. And then you think in your head, "That's a good pain," right? So anyway, thank you, ladies, for all your stories. They're all very inspiring. And as everyone can see here, everyone has a different story, right? Because we're all at a different phase in our disease, and we all experience this treatment a lot differently. So we all know it's not a cure, but it's certainly helped a lot of us, and we are grateful and thankful for that. So on that note, I'm very pleased to introduce our next speaker, who is Dr. Joseph Hewitt, who has traveled from California to be with us tonight. And I think he brought the sunshine with him. Do you think so? Yeah. Dr. Hewitt is a graduate of the University of California, San Francisco, which I have learned is his favorite city in the world, after Vancouver. Good one, good comeback. He completed his residency at Duke University Medical Center and his subspecialty fellowship training in vascular and interventional radiology at the University of North Carolina, Chapel Hill School of Medicine. Dr. Hewitt practices interventional medicine and has extensive experience in all aspects of minimally invasive surgery, including treatment of venous insufficiency. He is the only interventionalist in the world who has trained with Dr. Hakey in his facilities in Detroit, and I think everybody knows who Dr. Hakey is. Dr. Hewitt co-founded Pacific Interventionalists with a firm commitment to advance the practice of medicine through the studied use of minimally invasive, image-guided techniques in the treatment of vascular, musculoskeletal, and oncologic disorders. He can tell you what that means. And you probably saw as you walked in, there was some pamphlets and some CDs. The CDs are of his facility in Orange County, California, Newport Beach, close to the beach. So I'd like to welcome Dr. Hewitt.
Thank you, everyone. I'd like to sincerely thank you for inviting me into your home tonight. It's been a while since I've been to Vancouver, about 30 years, since my mother and father packed my brother and I, and my sister, into our Honda Civic and drove us from southern Manitoba all the way along the Trans-Canada Highway all the way out here. So needless to say, this time I took the plane and I didn't have my sister poking at me the entire time. Well, let's get at it. I'd like to talk to you about some treatment fundamentals and reintervention for difficult cases that we've seen in Southern California. My group is specific interventionalists, and this is a typical MRI of what we see with a person with bilateral jugular vein stenosis. Right now, we're seeing approximately 2 to 4 people every week for reintervention in Southern California. These are people who've had treatment elsewhere and are presenting with recurrence of their symptoms. We found there's 3 general categories that result in a reintervention: undertreatment, undersized stent placement, and incomplete treatment. In general, undertreatment results from insufficient dilatation of the stenosis or of the valve where the abnormality occurs. We often see underdilatation of the jugular valve. We often see pictures from previous procedures where the dilatation was performed with a balloon that's too small in diameter. We regularly lose quite large balloons up to 22 millimeters in diameter. Multiple angioplasties are often required. It often requires multiple times angioplasting the lesion, the stenosis, or the valve in multiple different fashions in order to achieve the durable result, the wide patency of the vessel. It will often involve disruption of the valve, particularly in the jugular veins. And this disruption of the valve often requires extraordinary means, including scoring of the stenosis. And you'll see some more of that. This is a very typical appearance of a patient who presents to us with recurrent symptoms. This is the left internal jugular vein. You'll see there's a catheter up in the jugular vein, and then it narrows at the valve. The valve in general occurs down in this area right here. We put a balloon in to demonstrate the size that was used previously to dilate this lesion. This is about an 8 or a 10 millimeter diameter balloon, which is an insufficient size to attain a durable result in a long-term patency. You can see that this balloon, which is about a 16 millimeter diameter balloon, you'll see we call that a waist. That's at the level of the valve. And in the jugular veins, it's all about the valve. We have to disrupt the valve to attain a long-term and durable result. Now you look at this, and although it may be subtle, it does look better. We're still not satisfied with that. What I can show you here is the real-time dynamics of the blood flow, which we can see very well at venography. It's one of the reasons why venography does still remain what we consider the gold standard for the evaluation, because it allows us to see the actual flow through the areas of abnormality. So we decided this wasn't good enough yet. So the valve wouldn't respond to a typical large caliber balloon dilatation, so we put wires around the balloon. This allows us to score the valve. It'll sometimes allow us to open up very resistant valves in a much more effective fashion. Unfortunately, that didn't respond to the scoring, so we had to revert to a technique we call bimodal asymmetric balloon dilatation. This will involve putting up 2 balloons, in this case, 2 8 millimeter diameter balloons, creating an asymmetric force on the valve, which, go ahead, David, resulted in a wider patency. You can see just looking at it that it is bigger. What I can't show you is how much better the flow was. And this is really what it takes. It's not just a matter of blowing a balloon up and seeing that it's slightly larger. We have to do whatever it takes, and it often requires, I tell patients, 2, 3, 4, 5, 10 angioplasties to really open that valve up and really try and return the flow, the venous blood flow, to its homeostatic state, or as close as possible. Unfortunately, we see a number of patients who present to us due to undersized and or malpositioned stents. Watching the news last night, I've come to understand this is a very important subject to many of you. I would say that the most important part of this is that the treating physician needs to know that you need to use large balloons. If one is going to use knows that one needs to use a 20 millimeter diameter balloon, one obviously needs to know that a 10 millimeter diameter stent is not sufficient. So that's the first rule I like to impart upon physicians who do this procedure. The problem with small stents is that if they're too small, they're going to migrate. You've probably all heard the horror stories of a stent migrating into the heart. That's one thing that can happen. That's very rare. Okay? Much more common is that these small stents do not restore the normal homeostatic venous flow dynamics that we're trying to achieve. Putting that small stent in there can actually have a reverse effect. It can worsen the flow. And as Dr. Cole alluded to, if we don't have good flow, it can actually act as a nidus for thrombus, blood clot formation, and restenosis, which is what we're trying to avoid, of course. This is a typical patient who presented to us. This is an individual in his late 40s, I believe. He had MS for approximately 20 years. He had his jugular vein reopened there on the right side and presented with recurrence of his symptoms. The arrows point to what is difficult to see, but it's a 10 millimeter diameter stent placed at the base of his right internal jugular vein. The remainder of his vein is occluded and clotted, thrombosed off, essentially very little to no flow. It's a little bit stronger injection with what we call digital subtraction angiography, so you can see it better. Again, the white arrows point to the stent at the bottom of your screen. The venous blood coursing up through this odd channel, partially through the native jugular vein, but also mostly through the collaterals. This is what the vein looks like after we perform hemomechanical thrombectomy. In other words, we instill medicines and we chop up the blood clot to remove it. And we perform angioplasty. You can see at least now we have a channel, a clear channel from the venous sinus within the skull at the top, down through the base. This, however, is inadequate, and you can tell just by looking at it that that's a very small vein, right? It's about the size of the stent that was put in, 10 millimeters in diameter, but obviously smaller than we'd like. This is what it should look like. This is after we've dilated the entire vein to 18 millimeters. And unfortunately, in some of these reinterventions, we do have to place further stents. This patient now has a large caliber flow throughout the entire channel, and so is restored from a state of essentially no flow and recurrence of symptoms to, once again, alleviation of symptoms and a very large caliber patent vessel with normal venous hemodynamics. We also, unfortunately, see a number of people who come to us having had incomplete treatment. We like to think of ourselves as being extremely thorough with what we do, looking at every possible vein. Jugulars, external jugulars, azygous vein, all of the above. 50% of our patients actually present to us without having had the azygous vein ever evaluated, unfortunately. So that's one of the first things we do is we look at the azygous vein. As Dr. Cole described, the azygous vein has a unique position in the body such that it lies adjacent to a bony prominence, the spine, and it lies behind the contents of the mediastinum. The mediastinum contains your heart. This can cause a compression, and as such we found that a number of our patients need a stent to be put in the azygous to maintain its patency. Go ahead, Dave. This is an example of a patient who presented to us with prior azygous vein intervention. A little bit difficult to understand. This is a big blood vessel called your superior vena cava. This is the azygous vein coursing up. There was actually a stent placed at the end of this arrow, and that was a 3 millimeter diameter stent placed in an azygous vein. I can tell you a 3 millimeter diameter stent is something that we put in a cardiac artery. Very, very small. Okay? And as you can see, the body's smart. It's formed collateral pathways trying to get around the area of stenosis, the area of narrowing. But as Dr. Cole alluded to, collaterals are never a substitute for normal venous flow, ever.